The prescription does not change in summer. The pill is the same, the dose is the same, the name on the bottle is the same, but the body swallowing that pill in July is not the body that swallowed it in February. And the medication operating inside a heat-exposed, potentially dehydrated, vasodilated senior body does not behave the way it behaves in the cool, well-hydrated body of winter. That difference between what a blood pressure medication does in February and what it does on a hot July afternoon is one of the most important and least discussed truths in senior health. And it is responsible for a pattern that repeats every single summer in emergency rooms around the country. Seniors who are stable, compliant, and well-managed are arriving in crisis not because the medication changed, but because the summer changed the body the medication was operating in, and nobody had prepared them for that. I'm Dr. Eleanor Bennett. Subscribe to this channel before we continue, because what I cover here is the kind of practical, seasonal, life-protecting guidance that should be part of every blood pressure conversation as spring turns to summer. It almost never is. Today it is. Let me start with the physiology, because understanding what heat does to the cardiovascular system of a senior is the foundation of everything else I am going to tell you. When the body is exposed to heat, blood vessels near the skin dilate widely to radiate heat outward. Heart rate rises. Sweating pulls fluid from the bloodstream. Together, these responses represent the cardiovascular system working at significant extra capacity simply to maintain a survivable core temperature. In a younger adult, the body compensates efficiently. The person feels hot, but not in danger. In a body over 60, every part of that compensation is less efficient. Arteries are stiffer. The nervous system responds more slowly to fluid shifts. The kidneys work in a narrower margin of adequacy. The thirst mechanism is blunted. Seniors can be significantly dehydrated before feeling thirsty. The heart has less reserve to absorb sudden changes. And blood pressure medication, arriving into that already stressed system, changes summer from uncomfortable to dangerous. Let me start with amlodipine, because amlodipine's summer story is the one that surprises patients most. Amlodipine works by relaxing the smooth muscle and artery walls, causing vasodilation, reducing resistance, lowering pressure. In winter, in a well-hydrated body at rest, this effect is controlled and predictable. The dose was calibrated for that body in those conditions. But in summer, the body is already vasodilating extensively to manage heat. The skin vessels are wide open. The peripheral resistance is already lower than usual, and amlodipine arrives and lowers it further on top of an already dilated system in an already compromised fluid environment. The result is blood pressure that can drop further and faster than either the body or the medication was designed to produce alone. Not in a dramatic, obvious way. In the quiet way that makes a senior feel washed out on a warm afternoon, slightly unsteady when standing up from a garden chair, vaguely weak, in a way they attribute to the heat rather than to a blood pressure that has dropped below what the brain and kidneys need. Francis was 68, on amlodipine for 3 years, managed beautifully through every winter and spring. Then July arrived, a week of unusual heat, temperatures climbing into the 90s by early afternoon. Frances was careful. She stayed indoors, used the fan, kept the curtains drawn. But the indoor temperature still climbed into the low 80s by late afternoon. She was drinking, but not as much as she should have been. The heat had suppressed her appetite, and with it her fluid intake. On the 4th day, she stood up from the sofa after her afternoon rest and the room moved. She sat back down quickly. She checked her blood pressure and found a reading significantly lower than anything she had seen in 3 years of careful monitoring. Her medication had not changed. Her dose had not changed. The season had changed, and the body that dose was operating in had changed with it. The amlodipine that was perfectly calibrated for February was too much medication for the vasodilated, mildly dehydrated body of a hot July afternoon. Now, let me tell you about losartan and lisinopril in summer, because for these medications, the ARBs and ACE inhibitors, the summer danger is centered not on vasodilation, but on the kidneys, and it is quietly more serious. Losartan and lisinopril both work in part by altering pressure dynamics inside the kidney's own filtering structures. This effect is protective under normal conditions. It reduces the mechanical stress on the microscopic filtering units called glomeruli and slows kidney disease progression in at-risk patients. But this protective mechanism depends on adequate fluid volume in the blood. The kidney needs sufficient circulating blood to maintain even the reduced filtration pressure that these medications produce. When a senior on losartan or lisinopril becomes dehydrated in summer through sweating, through inadequate fluid intake, through the combination of heat and the blunted thirst that comes with age, the blood volume drops. The kidneys receive less blood than they need. Losartan, or lisinopril, still present and still working, reduces the filtration pressure in a kidney that already has inadequate perfusion. The two forces combine, filtration drops sharply. Waste products that should be cleared accumulate. And the kidneys, within hours to days, can slide into acute stress, what medicine calls acute kidney injury, that can require hospital intervention to reverse. This is not a rare catastrophic event. It is a pattern that repeats throughout every summer in patients who are stable and well managed in every other season. Because the dehydration threshold that triggers kidney stress is much lower in an older adult on these medications than in a younger or unmedicated person, the margin of safety in summer is genuinely narrower, and most seniors have never been told that. Let me tell you about Howard. Howard was 74, meticulous, deeply proud of his medication compliance. He had been on losartan for 5 years without a single concerning lab value. He took his pill every morning at 8 without fail. Then came a summer heat wave, 5 days of temperatures above 95 degrees. Howard was active in his garden despite the heat, because the garden was his retirement and he refused to let summer stop him. He was sweating heavily. He was drinking, but not enough. His mornings were fine, but his afternoons were hot, and he did not refill his water bottle as often as the conditions required. He took his losartan faithfully every morning of the heat wave, proud of his consistency. By day 4, he felt wrong in a way he could not name. Not sick exactly, not dizzy, just profoundly inexplicably wrong. His wife noticed his urine had darkened. He did not go to the emergency room because he did not think he was sick, he thought he was hot. When he finally went the next morning because the wrongness had become undeniable, his kidney function had deteriorated significantly. He was admitted. He recovered. But the recovery took 3 weeks and left a kidney function baseline that was measurably lower than the one he had carried into that summer. The medication had not poisoned his kidneys. The combination of his medication, his dehydration, his heat exposure, and his faithfulness to a dose calibrated for a well-hydrated winter body had created a perfect storm that nobody had warned him was possible. Before I tell you about metoprolol, there is one more medication category that deserves its own summer warning, and it is one that millions of seniors take alongside their blood pressure medication, without realizing that summer transforms it from a helpful tool into a potential accelerant of the very danger I have been describing. Diuretics, water pills, hydrochlorothiazide, furosemide, chlorthalidone. These medications work by prompting the kidneys to excrete more fluid and sodium-reducing blood volume and thereby lowering pressure. In the controlled fluid environment of winter and mild weather, they are effective and well tolerated. In summer, they become a compounding factor in a dehydration equation that is already tilted against the senior taking them. A senior on a diuretic is starting every summer day with a medication that is actively removing fluid from their body. Add heat, add sweating. Add the blunted thirst of an older adult who does not feel the urgency to drink that the fluid loss demands. And the dehydration that builds over a hot afternoon is not starting from a neutral baseline, it is accelerating from a starting point, already pushed toward depletion by the medication taken that morning. When a diuretic is combined with losartan or lisinopril, a combination that is extremely common in senior blood pressure management, the summer risk multiplies. The diuretic reduces blood volume. Losartan or lisinopril alters kidney pressure dynamics. The hot weather accelerates fluid loss. The aging thirst mechanism fails to signal the shortage. And the kidneys, caught between 3 converging forces all reducing their perfusion, can slide into acute injury in the space of a single hot afternoon. Sylvia was 76, on hydrochlorothiazide, lisinopril, and amlodipine, a common triple combination for blood pressure control. Her winter and spring management had been excellent. In early August, she spent a morning helping her daughter move furniture, not outdoor work, but physical exertion in an apartment without air conditioning on a 90-degree day. She drank 2 glasses of water over the course of the morning and thought she was being responsible. By afternoon, she felt a fatigue that was qualitatively different from ordinary tiredness, heavier, stranger, oddly unconnected to what she had done. Her daughter brought her home. That evening, her legs cramped severely. The next morning, she could not stand without the room tilting. At the hospital, her sodium was critically low, her kidney function had deteriorated, and her blood pressure, despite 3 medications, was swinging unpredictably. She was admitted for 3 days. Nobody had told Sylvia that her 3 medication combination, each individually appropriate, each correctly prescribed, became a fundamentally different pharmacological landscape in the conditions of that August morning. The drugs had not changed. The summer had changed everything around them. Now let me tell you about metoprolol in summer, because beta blockers add a specific summer danger that is almost never discussed and that can mask a life-threatening situation. Metoprolol slows the heart rate and reduces cardiac output. In a patient with heart rhythm problems, angina, or post-heart attack risk, this is exactly the protection the medication provides. But the heart rate is also one of the body's primary responses to heat. When the body is hot, the heart beats faster to increase blood flow to the skin and maintain cooling. It is a heat dissipation mechanism. Metoprolol blunts that mechanism. In a senior on metoprolol, the heart rate cannot rise as freely in response to heat stress. The body's ability to regulate its own temperature is reduced. The warning signals that would normally alert a person to serious heat stress, a pounding heart, a racing pulse, are dampened. And the internal temperature can rise further, faster, with fewer external signals that something dangerous is happening. This is why seniors on beta blockers are at particular risk for heat exhaustion and heat stroke in summer. Not because the medication is wrong, because it removes one of the body's most important early warning systems at exactly the time of year when that warning system is most needed. Beatrice was 72, on metoprolol for a heart rhythm condition. She attended her granddaughter's outdoor birthday party 90 degrees, full sun, 3 hours. She felt warm but not alarmed, no pounding heart, no racing pulse. By the second hour, she felt confused in a way she could not name. Her daughter noticed incomplete sentences. Her skin was hot and dry, not sweating, which should have been the signal but was not recognized. Beatrice had early heat stroke. Her core temperature, when paramedics arrived, was dangerous. She recovered, but the event that had felt merely warm to her had been a medical emergency, and metoprolol had silenced the warning bells her body would otherwise have rung an hour earlier. So what does a full summer of unmanaged heat exposure actually do to the organs of a senior on blood pressure medication? Because the individual episodes I have described, the afternoon pressure drop, the kidney stress, the heat stroke risk, are each serious on their own. But the cumulative picture across 3 months of summer is the one that changes long-term health trajectories in ways that a single winter lab test may not reveal. The kidneys experience repeated episodes of reduced perfusion across a hot summer. Each episode may resolve without obvious consequence, but each leaves microscopic traces that accumulate. The kidney that emerges from August may have measurably less filtering capacity than the one that entered June, not because of a single dramatic event, but because of repeated small insults that individually seemed manageable and collectively became significant. The heart adds to a cumulative workload across every hot afternoon. Each swing below optimal pressure, each extra effort to maintain brain and kidney perfusion with lower than ideal blood volume. The September fatigue many seniors feel sometimes reflects exactly this cost, and the brain, exposed across an entire summer to repeated moments of suboptimal circulation, can show the kind of cognitive change that gets called aging when it might more accurately be called 3 months of inadequately monitored blood pressure medication in summer conditions. Arthur was 78 and had what his family described as a difficult summer. More confused in August. 2 falls attributed to heat or bad luck. Erratic September blood pressure. Shifted kidney labs. His doctor recognized it not a new diagnosis, but an accumulation. A summer without a plan. The summer had made its own plan for him. So what does the summer plan for a senior on blood pressure medication actually look like? Because this is where the video becomes practical, and every point here is something you should know before the hottest days arrive, not during them. Hydration before thirst. The thirst mechanism is unreliable after 60. Do not wait to feel thirsty. Set a fixed routine, a glass of water at waking, with every meal and in the mid-afternoon, regardless of how you feel. In summer, on blood pressure medication, this is not a preference. It is a safety protocol. Know your temperature thresholds. Indoor temperature above 80 degrees. Outdoor activity above 85. Sweating heavily for more than 30 minutes. These conditions change how your medication is behaving inside your body. They are not just uncomfortable. They are physiologically significant. Take your blood pressure in the afternoon during hot weather, not just in the morning. Morning readings in summer often look acceptable. Afternoon readings after hours of heat exposure and inadequate hydration may tell a completely different story. Have the sick day conversation with your prescriber before summer begins, not during a heat wave. Ask specifically, if I have a day of heavy sweating or poor fluid intake, what should I do about my medication? Which of my medications needs the most careful management in heat? At what point should I call rather than manage at home? Those answers in advance are worth more than any emergency room visit they prevent. Know the warning signs that demand immediate action. Not just the dramatic ones, not just fainting, not just chest pain, the subtle ones. urine that has darkened significantly, which signals dehydration that has already become significant, unusual weakness or confusion in the afternoon that is not explained by the temperature alone, a blood pressure reading that is dramatically lower than your usual range, a sense of being profoundly wrong in a way you cannot name but cannot dismiss. These are the signals that should override pride, override inconvenience, and override the desire to wait until tomorrow and see. And if you are on metoprolol, tell the people you spend summertime with. Tell your family and friends at outdoor events that your heart rate does not rise the way theirs does in heat, that the usual warning signals of heat stress may not appear in your body the way they appear in theirs. That confusion, hot, dry skin, without sweating, and unusual disorientation are signals to act on immediately, regardless of whether you feel alarmed yourself. Summer is not a season to take blood pressure medication casually. It is a season to take it intelligently. The pill is the same, the dose is the same. The challenge is understanding that the body receiving it has entered 3 months of conditions for which that dose was never calibrated, and responding with the awareness and preparation that those conditions demand. Frances made a summer plan. She tracked her afternoon blood pressure for the first time. She set water reminders. She told her daughter what to watch for. She asked her prescriber the sick day questions she had never thought to ask. That summer was the first in 3 years without a single afternoon episode that frightened her. Same medication, different awareness. And awareness in summer, after 60, on blood pressure medication is the difference between a dangerous season and a safe one. Share this video with someone who takes blood pressure medication and has not yet thought about what summer means for the way it works. Subscribe to this channel, and I will see you in the next video.